Good afternoon, everyone. You can hear me? Thank you very much for joining today's session. Today we'll be talking about protecting healthcare workers from COVID-19 beyond the hospital setup. My name is Dr. Nancy Ngumba. I'll be moderating this session with the help of Dr. Rosa Chemwe and Dr. Agnes Karingo. And today we have a very interesting presentation. We'll be listening to experiences of staff who've actually been infected with COVID-19 and having the opportunity to ask them any questions that we have concerning COVID-19, even as healthcare workers and as we face this. Listening to yesterday's news, there was a report of staff in Wasingishu who are infected with COVID-19, and I think this webinar is now timely. So what do we do? What are the steps forward? How has the experience been, even as staff, even as we face patients who may expose us, and even as we're in the community where COVID-19 is there? So this will be a very, very interesting presentation. I've seen several comments concerning CPD points. Kindly email us at knetcpd@gmail.com, and for pharmacists at cpdpharmacy@gmail.com, and we'll be able to address any issues concerning CPD points. Before the emails, kindly check in with your registration number and see whether your CPD points have actually been uploaded. So right now, I'll hand over to Dr. Rosa Chemwe, who will give a presentation and introduce the speakers. Thank you very much. Thank you very much.
Thank you very much, Dr. Ngumau. This is actually a very timely presentation because the frontliners are now being a part of the statistics, and we need to meet and talk and see where our gaps, where our successes. So together with Dr. Agnes and Dr. Ngumbau, we have four panelists who've joined us, and they'll share their experience, who had been confirmed. They're healthcare workers at the front line of this battle, and they've been confirmed to have COVID. Some have recovered, some are still undergoing treatment, and they'll share their experience and their journey, how it has been. So like Dr. Ngumau said, this is going to be very, very interactive. So karibu sana Dr. Amina Guleit, Dr. Marina Mbongori, Dr. Kwame Gwantai, and Dr. Maina. Karibu sana to the panel, and we look forward to hearing from you. And as you open up your heart and share your experience and even the recommendation of how Kenyatta National Hospital can move forward when it comes to managing COVID-19, when you're on the other side of the coin. So I'll start briefly by just doing a small introduction and sharing a little statistics on what is happening in KNH. I know our participants are from all over the country, but this is just what is happening in our community here in KNH UON. So one of the important things we need to realize as healthcare workers, people working at the front line, is our own actions and our own behaviors are the things we can control. We may not be able to control for other people, but we are able to control our own. And this is one of the key things we are going to look at. So KNH is not alone in having healthcare workers being infected. As you remember, in Pumwani some time ago, we had 15 nurses who also tested positive, and this brought quite a bit of some chaos. A total of about, at this time, we had about 249 healthcare workers who had been confirmed to be COVID positive. We remember one of our own who sadly lost the battle, Dr. Lugaliki. This is one of our recent colleagues from Homa Bay who also lost the battle to COVID. However, we have successes, and today we'll talk about the success stories from our own healthcare workers, how the journey has been. So to just give you a little brief on the statistics we have at the hospital is in terms of age distribution. You can see the age group above 45. They're actually accounting for, these are numbers, 44. The total number we have in KNHUON that tested positive is 176. This is between the month of mid-June to yesterday, 44 in number, which actually represent 19%. Sorry, that should be 48%. And then we have between 30 to 34, that were 42 in number, 42 out of 176. And then you can see the youth, below 20 to 24. The youngest we had was actually a 20-year-old, and there are very few between 20 to 24. Yeah, just about 6 out of the total number that we tested. So between the ages 30 to 34 and above 45, these are the ones who are actually having the most infection. Sorry about that. And then when we look at sex distribution, we know nationally that males are much more infected, but here in KNH, what we are seeing is not much difference, because for the males we have 48%, and then for females is 47%. It's not a big difference. So we have some missing data, so we don't know where exactly 5% lie, whether they are males or female, but we're seeing more or less similar distribution. If you look at the cadre, which is quite interesting, the nurses who form the majority of the staff actually had 34 out of the 176 that were tested, and this represented 19%. So interestingly, if you look at the staff that support the system, the healthcare system, so that it can work smoothly. These are the allied staff, people in administration, cash point, finance. Their total number is equal to the number of frontline workers. So one would ask, what is happening? Why are we seeing this picture? Are people acquiring COVID in the community, or where is exposure happening, and where are we letting the gap? Where are we falling in between the cracks? So for clinical officers, we've had 2, public health officers 1, and the support staff is 8. So as for the doctors, it's almost aligning those of the nurses. We had 29 out of the 146. Now, just to give us a status as of today morning, we are not doing too badly, because it would be nice not to focus so much on the negatives, because as much as we have cases rising at 22,000, we have quite a bit of a recovery. Our recovery rate is about 39%. If you compare with the rest of the world, it comes to about 63%. Brazil is about 69%. The US is doing about 50%. So we are heading there, and we need to talk as healthcare workers to see, where can we beef up our actions so that we cut this infection from spreading. So at this point, I would start a discussion with the healthcare workers that we have on board, the 4 that I had mentioned. And I'll start with Dr. Amina Gorey. Could you please introduce yourself and maybe tell us where you work, where is your workstation?
Good afternoon. How are you? Thanks for the opportunity. My name is Amina Gulid. I work in Kenyatta, specifically Universal Healthcare. Yes, Rosa. Apart from the introduction, maybe a couple of words. Before I tested positive, which was around 19th of June last month, I was basically doing a lot of COVID work, and you get to see a lot from a bird's eye view from the position that I was in, because I wasn't doing the hands-on job. Mine was like the administration mostly. So I was doing mostly quarantine work, the exposure, because in Kenyatta what we had was the IDU and the main hospital. And as the numbers started increasing, we started having positives in the hospital. So I remember the first case, and in the particular first case, there was a baby who died, and almost 33 healthcare workers were quarantined. Most of them had a lot of interaction with the baby, including intubation and what have you. Fortunately, weirdly or fortunately, none of them were infected, and a similar case happened. It was quite interesting. But now as the numbers started increasing and everything of that sort, as healthcare workers, including I, started getting infected. And personally, the biggest advice I can give somebody, especially the ones who are symptomatic, because what happened for me was I suspected I acquired it from the community, because I rarely interact with like COVID suspects or positive patients in the hospital for me to have that thought of I'm getting corona from the hospital. And plus I do my social distancing except from a few people. Yeah. So what I would advise healthcare workers is, if they develop the few symptoms that we know of, which is cough, runny nose, a sore throat, if you could isolate yourself and take yourself, especially when since we are high risk factors, we isolate ourselves immediately and we go and get tested. It will really help also in terms of reducing the spread. Yeah. Rosa, I think now that's a brief introduction, maybe the other people, and then if there's any questions, maybe I can answer or something.
Okay, definitely. We'll come back and do a round of other questions, but it's good to actually hear from you. I know we've been working together, and hearing your voice again is quite exciting.
Yeah.
So maybe you can introduce McKenna. You can take over, introduce yourself, just give a brief of how it was when the news was broken to you, generally. Caribou.
Good afternoon, everyone. You can hear me?
Yes, we can hear you.
Okay. Dr. Marina Caribou. I'm a resident orthopedic surgery at Kenyatta. Tested positive, say 2-3 weeks ago. So for me, of course, it's difficult for me to try and guess where, or to try and assume where it came from. But my story is a bit different, because what happened is that a very close family member of mine is the one who started exhibiting symptoms, and he's much older and has comorbidities. So the testing actually came from testing them first, and they turned positive. Before now, I tested myself. I did not have any symptoms at all. But once they were tested and turned positive as a contact, I was also tested and now turned positive. So luckily, and I thank God, I've not had any symptoms. I think the few days in, I had maybe a bit of a running nose and just like normal flu-like symptoms, which to be very honest, I think I would have probably not taken too seriously. And this is now another part that maybe we'll discuss, because I did not have the classic cough, fever, dyspnea, that is maybe being used as the criteria for admission and all that. It was just running nose and blocked nose, and it was already July. It was the cold season, so there's all this flu going around. But the fact that my close family member and we are in contact was tested positive, then I had to be tested. So I've been in quarantine, or rather isolation. And another now aspect I want to bring in is that even after 14 days of quarantine, still turned positive again after retesting after 14 days. So, and of course, I've done a lot of research and reading about it. And there are some studies showing that some people remain positive for quite some time, up to even 6 weeks to 40 days. And the theory is that it's probably not the active infection, it's probably the RNA shedding from the viruses that are not active. Maybe someone who has more information on the science. As I mentioned, I'm into orthopedic surgery, so for me, it's all about the bones. Sometimes this infectious disease, it's still, I'm also just like a normal, sometimes it's difficult to grasp the whole aspect of it. So that's where I am. I'm on like my second round of quarantine because tested positive again. But otherwise, no symptoms. My family member as well has no symptoms currently, keeping healthy, vitamin C, trying to be active, trying to be positive. Also, we are not, especially for us healthcare workers, we're not used to being idle. Ever since you joined med school day one, you've been active, up and down, up and down. So, having to slow down a bit, but anyway, it has its advantages. You can also still work, online classes, trying to work on some of the documents that sometimes you don't get time to do very well because you're always up and down in the hospital. So for me, I think the issue would be that after retesting and remaining positive, and I think a lot of healthcare workers, that has happened to them. So how long are you going to be out of work until, do you need to have turned negative completely twice, 2 negative results 24 hours apart for you to go back to work? What is the new recommendations and what are we doing? So open to more questions. Thanks, Rose.
All right, thank you very much, Dr. McKenna. We actually have in our panel Dr. Nyukuri, who's an infectious disease specialist. So he will be talking a little bit about retesting and what we should expect, or what is the ID recommendation on that. So at some point, we'll give him that opportunity to discuss that aspect. But McKenna, you actually raised very pertinent questions on this COVID and healthcare workers, which we will delve a little bit later into. So we'll introduce our last panelist, Dr. Marina Caribou. You can introduce yourself and just give briefly how the breaking of the news was and just an overview of how the whole experience has been.
Good afternoon. My name is Marina Caribou. I'm a fourth-year resident in Obsgyne. I tested positive on the 21st of July. This was my second major exposure. My first exposure was with the baby, patient number 4, whom I knew on a personal level. So I did the 21 days quarantine at that point. And at that point, I did the chattings and had 2 negative tests. So I returned back to work. So my second exposure I'd attributed to a patient I was taking care of. I believe my exposure started on the 7th. In Obsgyne, we have a rota that caters for us. So we have the doctors being on duty for 1 week, then 1 week we are off. So during that week, I was in constant exposure with this patient, and then the patient turned positive. So on the Saturday of the 11th, I began having a mild cough, but since it was July and I am highly atopic, I am an asthmatic on Ventolin and Flolarin. So I naturally assumed that this was asthma or an exacerbation of the same. So I continued charting my temperatures and saturations and whatnot. And on the 15th, the cough became worse and I lost smell. And that's when I went and tested. So I, at that point, started on symptomatic treatment. I started on azithromycin, zinc, paracetamol, the traditional dawa, and lots of citrus fruits. 16th, 17th, everything was fine. But on the 18th, my saturation started to fall. And on the 19th, I had sub-80s saturations. And at this point, I decided to go to hospital. They ran a CT scan and labs, which showed that my D-dimers, fullimograms were all deranged. The CT scan showed bilateral large ground glass appearance with COVID-like pneumonia bilaterally. I was admitted and started on oxygen, but my saturations still were subpar. And on the 21st, we started on high flow. This is at the point when Kenyatta confirmed the diagnosis. This was 5 days after testing. So that was rather a huge delay. So I did high flow for 7 days. And from there, my saturations stabilized well enough to be discharged on the 1st. And yeah, currently I'm on home-based care, have a mild cough, mild exacerbations of loss of voice sometimes, but generally fine. Thank you.
Thank you very much, Dr. Marina. And I know this is it was not a very, very easy journey, especially having gotten a severe disease and, you know, having desaturations and being a medic, you actually know what is happening. It makes it even much more difficult. So, and you've just been discharged from the hospital. So we continue to celebrate you guys for this courage that you've taken to share with us what you've gone through and, you know, to educate some of us on this experience that we may not be privy to. So we have our fourth panelist, Dr. Koome Gwantai. Please just introduce yourself. Where is your workstation and how overview the journey has been from when you tested positive?
Hello, everyone. I hope you can hear me.
Yes, we can hear you.
So I tested positive. I did my first test on 17th of the month, approximately 2 weeks and 5 days ago. What precipitated the test is that I had come into contact with a patient who in Ward 5A, a relative of mine from upcountry, who had been admitted for an elective procedure. And the doctor called me a few days later and told me that he had tested positive. At which point I'd actually started having some flu-like symptoms. Despite the fact that it's a month of July, they were a bit extreme in the nature of the fact that I was a bit, my like temperature-wise, I was feeling cold. Although I never really had a fever, the feeling like chills and rigors, but there is no fever per se. I did the tests. The results came a bit late because they came back after like, I think 6 days, because I got them on Thursday, the following week. They said I have COVID. I was advised to go on a quarantine at home. I have not had much in terms of any noticeable symptoms, except for like easy exacerbation, like especially if I go up like 4 or 5 flights of stairs, the chest becomes really tight. You feel like your chest is literally bursting out. But at the moment, I'm fairly doing well. Cannot really complain. Just hydrating, sleeping a lot. I did my post-test on Monday. That was the day before yesterday, I think. Or was it yesterday? Okay, one of them. I'm not really sure. Oh, it was yesterday. The results are to come back in like they told me between 2 and 3 days. So just waiting to see what comes out of it. Other than that, just an advice to the healthcare workers out there. At the moment, a lot of community transmission. There's a lot of community transmission, and we're actually admitting patients in the ward. I'm currently working, I'm a registrar in Kenyatta. Currently, we're admitting a lot of people who later turn out positive. The only challenge is the delay that comes in getting the results, because at times the results come back after like between 4 and 5 days, at which time the patient has been in contact with a lot of hospital staff, a lot of other patients. Basically, it's like a chain of infections. Case in point, we have like a mini kind of situation in the ward I'm currently working in, where one patient tested positive and then ended up like with 7 other tests positive. And that's a patient who's actually been in the hospital, I think for the past like 2 years. So it's quite tricky. So I will just urge all of us to treat all patients out there we see as possible patients or possible persons who are infected with COVID. That mask is very important. It's very important. It could save you a lot of hassle. Thank you very much. We'll follow the discussion as we go along. We are told to give some suggestions. I think we'll give them the suggestions as we go along in the discussion. Over to you, Dr.
All right. Thank you very much, Dr. Kwantai, for sharing with us your experience. And indeed, we cannot really underscore the use of mask, because when you go into the community, sometimes you say you know somebody, you know your relative, and they look very stable, and you decide, now I can remove my mask, or maybe you're talking to each other and you decide, now let me just lower my mask, I put it under the chin so that I can now converse nicely. But we shouldn't let our guard down, whether you're in the community or in the hospital. So now that brings us to the second round of questions for our 4 participants. What is your experience with using PPEs? The N95 versus the surgical mask. Now there's a notion that is coming up right now that or an agitation actually that is coming up now that everyone needs to be on an N95. So we spearhead in telling the staff, clinical staff, that a surgical mask and N95 can work all the time. So during this time when you got maybe exposure, how was your use with the PPEs? So that maybe we allay some anxiety that may be coming up concerning N95 and the use of surgical masks and any other PPEs. Maybe we can start with you, Dr. Kwantai. You can share with us how that was during.
So at the beginning of the COVID pandemic, and when the hospital realized that we have a lot of cases coming in, we were supplied with initially it started out with surgical masks we were collecting from the administration office in the relevant wards we are working in. Then later the guys on call started collecting KN95 masks. I've come to realize there's a very big difference between the 2 masks. The KN95, which is commonly what you are using, does not confer you as much protection as the ideal N95 mask. Although the fact that the N95 masks are in short supply at the moment, for fear of my own and for fear of transmitting to other people, I actually went and acquired 1 piece, which I was using before my results came out. If it's possible, I don't know what the procurement procedures that actually take place in Kenyatta, but they do confer ample protection. But in real sense, even if you actually read from the literature out here, the KN95 mask is much, much inferior compared to the ideal N95 mask. I don't know what the experts opinion on this, because I noticed that the guys who work in the infectious disease unit and the guys in Bagathi, most of them actually have the ideal N95 mask. The one that has I think it even has some serial markings next to it. And that's because they are coming into close contact with patients of confirmed COVID cases. But as the situation is at the moment, all of us out here at the moment are actually almost on a daily basis coming into contact with the patients with the COVID-19. I don't know what they are working towards in that direction, but it feels kind of a bit of an unfair situation that the people in the infectious disease unit and in Bagathi Hospital, the initial time we are seeing they are getting the N95, the 3M N95 mask. But the other guys in the wards, the casualty, we are given that N95 mask that actually does not even fit very well. It does not fit, it does not form a proper seal. If you actually have worn it for a long time, it does not form a proper seal around your nose. You actually have to double up with a surgical mask so it can actually adhere properly to your face. With that in mind, I think the departments took a very good initiative in supplying most of the N95 masks. PPEs have not had a very good experience with them because the period that they're being introduced in the wards and in theater, that's the time that I've been on quarantine. So I can't really say much about them. I'll get to experience them when I go back to work. Other than that, over to you, Dr.
Okay, thank you very much, Dr. Gwantai. It's actually very, very important for us to get this kind of feedback as regards use of PPEs, because we've actually been spearheading the scaling down of PPEs. You remember when we initially started from our first case in mid-March, and we were advocating for the use of the hazmat suit. And now we've scaled down up to where now we are using the reinforced gown and the mask. And the mask can either be surgical mask or the KN95 or the N95, whichever is available in the hospital, or for those who personally purchase for themselves. So we've actually been encouraging on the rational use of the PPEs. And like you have mentioned, it's very important to look at the fitting, because we have different sizes, especially for this KN95, and the fitting is very important. Same to the surgical masks. We've been having some surgical masks that large fitting, others are small fitting. So it's very important for one to check the fit test, including those of the KN95 and the N95. As regards supplies, actually, this is something we have liaised very closely with our supply chain and the ward in charges at the point of use to make sure at least all the healthcare workers are supplied with the right PPEs. So, hearing from you, the experience you had at least will guide us to know how should we approach this PPE issue while we're on the ground at the point of use, which is very, very important. So thank you for that, that feedback. So Dr. Marina, what is your take during the time maybe you got exposed? How was your use with the PPE? Would you attribute anything maybe in terms of maybe you didn't use it well, or you used it well, it's just accidental? What is your take on the PPE use?
I'd say I was a bit overcautious. Being very atopic, asthmatic, I knew that if I got this disease, it would take me down. So I was always double masked on an K95 and a surgical mask. And the problem was K95s are not available mostly. So we are forced to recycle them. So you'll use one today, another one tomorrow, then reuse it maybe after 3-4 days. and so on. So I don't know if that contributes, I don't know. But I'd say my use of PPE was fairly good enough.
Okay, thank you very much, Dr. Marina, for that honesty about reusing. I know we live in times when we have real shortages, and sometimes reusing is some of the options that we opt for. But hopefully moving forward, the hospital has secured plasma sterilization machine. So hopefully we would be sterilizing reusable PPEs so that we don't have challenges with the PPEs moving forward. What about you, McKenna? What is your take?
I think it's pretty much the same as my colleagues. Actually, towards the time when I think the infection started, I was using the KN95 very diligently. Actually, my family members as well. Everyone was being very cautious, sanitizing, social distancing, and all that. And as I mentioned, I'm not exactly sure where I picked, or because I suspect I may have or rather, one of the theories is that I may have been the one to transmit to my family member who ended up turning positive, and then that's what prompted me to test, because of just being around the hospital environment, because they were not really moving around much. But either way, still, it's in the community, so it could have come from anywhere. But that's besides the point. But yes, K95, sometimes reusing, to be honest, sometimes only a surgical mask, especially when you perceive that you're not going to be in theater directly in contact with the patient. Maybe you are just moving through the hospital, or in the community, you tend to just wear a normal surgical mask, and then so I don't think, actually, for me, I never came into contact with a patient directly who eventually came to turn out positive. But so it could have easily been from the community or from someone who we never tested in the hospital. But yes, the use of PPEs was, I mean, just basic as what everyone is saying, not too overboard or not being lax.
Okay. Thank you very much, Dr. McKenna. So, as we agree, PPEs is very important, but we are seeing also some gaps that you can still get the infection even occasionally with the appropriate use of PPE. So it's still important to actually maintain the same standards that we talk about: hand hygiene, the right use of PPEs, social distancing, those kinds of things. So, to Amina, what is your take?
Yes, Rosa, what is my take? So, like I said, I was mostly in the administration section, barely dealing with patients. So my take is, for me, my basic PPE was a surgical mask, which I was doing. Like I said, my suspicion is I got it from home. That's my weakest link. Unfortunately, I've had a lot of family members who've had corona. I've had 3 relatives who've died of corona. Sorry, it's out there in the community. It's a fact. So sorry, I'm getting some calls. So what I can say is, when it comes to PPE, it really depends with which area you're located, because from my experience, which is now from the bird eye view, I started doing the quarantine properly and following up the patients, the exposed staff, with the second patient who turned positive in the main hospital. The patient was in A&D. We had quarantined 16 people. Patient had a gravid person who was exposed, which I forgot to mention. I'm also expectant, and I guess that's a brief history about my experience with COVID. My symptoms have been cough, no fever. I've been monitoring myself with the SpO2, unlike the temperature, because I'm more worried about my SATs than a fever. What else? My cough has been persistent. My results have been persistently positive for the last 5 to 6 weeks. I gave up on testing. Currently, thankfully, I'm asymptomatic. What else did I want to mention? Yeah, so for the PPEs, my personal opinion, and I was to collect the data properly, but unfortunately, we had this ton of events. In a more objective manner, because I've quarantined people who are exposed in main CCU, people who are exposed in medical CCU, people who have been exposed in theater, followed them up for a period of 21 days, some 14 weeks, tested them 2 times. At first, I was doing day 8 and day 14. Later on, as the community infection became more common, I started doing from day 1. Or if, let's say, we got a chronic exposure, like my colleagues have correctly put, sometimes we have delays in results, or sometimes we just have delay in suspicion. So we do the testing maybe 2 weeks after somebody has been in the ward, and we find out, oh, this person has been positive. Weirdly, most of the people who came into contact, even with a surgical mask and gloves, and they don't stay there for like more than even the ones who stay there for more than 20-30 minutes, to be honest with you, were all, if they were negative the first time, they were negative even in day 14. And I remember the first staff who was positive from the main hospital. It was somebody who was a support staff and had no contact, absolutely no contact with the patient in the ward, because now the whole ward was exposed. It was like a chronic exposure. So even he didn't even transmit the virus to his colleagues. So my take on PPEs is, because personally I'm positive, I don't feel like if somebody needs to see me, they have to be in a full suit for them not to get COVID from me. All the colleagues who I did not even do social distancing with, fortunately, have been negative. So what I'm trying to say is, it's PPE really varies with what level of invasive procedures you're doing with the patient. And even then, if you do them correctly, like if you do your basic IPC control correctly, wash your hands immediately, make sure you've been wearing your surgical mask immediately, and all of that, that will be effective. But now we need to remember, as healthcare workers, we go back home, we have kids, we live with many other people, and corona is almost everywhere right now. So you need to be cautious with the people who are around you, the people who you live with. You know, like the way we went for sensitization initially, I think we should do that sensitization at home as well. And yeah, I think that's about it. That's it from me, Rosa.
Thank you very much, Amina, for that insightful talk about the use of PPEs. And it's actually, we cannot really overemphasize it. So I know many questions, we have so many questions from our participants. So I'll hand over to Dr. Agnes to take over from the questions from the panelists. But what I would encourage the panelists, we want to make this very interactive, to put a voice to your questions. Please feel free to put up your hand and you ask your questions directly to our panelists. Thank you very much. Karibu, Dr. Agnes.
Thank you very much, Dr. Rosa. We have already had a lot of deliberations, and thank you our panelists for sharing your experience, Dr. Kwame, Dr. Amina Gule, Dr. Marina Bernard, Dr. Gorey. Thank you very much. A lot of questions about PPEs, and that has been we have really talked about it much. The other question that we may want to explore a little bit is on the viral shedding, on the viral shedding, the new CDC guidelines saying one thing: when do you come back to work as a healthcare worker? For how long do you after how long do you do the testing? And we'll pose this to infectious disease doctor who is with us here, Dr. Nyukuri, if you can hear me. He can talk a little bit more on that. Thank you.
Hi, Agnes. Can you hear me?
Yes, we can, Doc. Thank you.
Thank you so much. And thanks to the doctors who have taken their time to share their experiences with us. I think all of us have learned a lot. So I'd like to address two issues. One is when to end isolation measures. And the second one, which is related, when to resume work. So first, we ask ourselves when to end. For us to answer the question when to end isolation measures, we have to ask ourselves, why do we isolate in the first place? And of course, we know this is to prevent us or the person who is sick from transmitting the infection to the people around him or her. And transmission is greatest during the early phase of the infection. So the second question is, for how long is a patient infectious? So from studies done, it seems recovery of replicant competent virus, it depends on the severity of the infection the patient has had, and also the immunocompetence of the patient. So you'll find that in most patients who have had mild, moderate disease, or even who have been asymptomatic, replicant competent viruses have not been recovered past 10 days. And that's why the CDC guidelines actually do recommend that for patients who have had mild to moderate symptoms or who have been asymptomatic, 10 days of isolation is actually more than adequate. And this patient is no longer infectious and can end isolation. So what about patients who have had severe infection and patients who are immunocompromised? I'm thinking of patients who have malignancies, patients who have HIV and very low CD4 cell counts. So for this kind of patients, then they may remain infectious for longer. But again, even in these patients, past 20 days, they have not recovered replicant competent viruses. So if in this group of patients, then you can consider ending isolation after 20 days. Now, what do our guidelines say? What I've just said is the science. What do our guidelines say? So there are guidelines. You can either use a time-based or a test-based strategy. The test-based strategy is the one currently used by healthcare workers, whereby we do the testing, 2 tests 24 hours apart, and if both tests are negative, then the patient can end the isolation measures. However, we also have the symptom-based strategy, and this one is in patients who had mild, moderate disease, 10 days have passed, they have not had any fever for the last 3 days, and the symptoms have improved, then these patients can end the isolation. Now in hospital, I know we do not, currently we are using the test-based. Can we use the time-based? I think these are discussions that we need to have higher up. One of the challenges actually I know we are even having with our own patients, leave alone staff, is when we discharge patients from isolation and they need to come back to the wards. and we are insisting the patients have 2 negative tests before these patients are admitted. So I feel people need to be comfortable that after 10 days of isolation, the patient is no longer infectious. And once we healthcare workers buy into that, then we'll be okay interacting with our colleagues who are coming out of isolation without a repeat test, and interacting even with the patients who have completed their isolation period and now are coming for further procedures. For how long can a patient be positive? As you have seen from Dr. Amina, it can take very long. We've had patients who have returned a positive test 6 weeks, 7 weeks, or even more after the first initial test. So I personally feel in such patients, a symptom-based strategy is fine and it will do. When to resume work? Now, again, we know, yes, you might even have 2 negative tests, but COVID, especially for those who had severe disease, it really takes a toll on the body. And some patients, some might take more than 2 weeks, some even 4 or even 6 weeks before they come back to baseline. So I'll say after end of isolation, and if you're still feeling, you have not fully recovered, because I'm just thinking of this patient or of this healthcare worker who had severe illness and the lungs were pretty much damaged. I don't think you can return to work immediately after 2 weeks, especially if you are still dyspneic. You might require a few more times, quite a longer duration of time before you are fit to resume work. But I think these are discussions that you can now have with the doctor who's following you up to do the assessment and see when you are fit to resume work. I think I'll leave it at that. Thank you. Back to you, Agnes.
Thank you very much, Dr. Nyokori. That was really helpful. I think he has explored majority of what the participants were asking regarding the viral shedding and return to work. And that really depends also on the guidelines that we do have in your particular institutions, apart from the national guidelines that are being developed. Thank you very much. The other questions relate to part of the what are some of the national protocols or guidelines that we do have in regarding is home-based care different for the healthcare workers as it is different from, is there anything that is different from what we've been having for the patients that we've been discharging at home? And for that we'll have Dr. Rosa can comment on that. Dr. Rosa. Dr. Amina Guled, Dr. Amina Guled can comment on that. And we'll also have Dr. Amber Gorey as a comment.
Okay, so now maybe I can go into giving criticism on home-based care. I feel like we're not doing home-based care correctly. I think I might be wrong. The Jitenge app, when I was in, I don't know, maybe they updated it, but it's good I give out the criticism. So yeah, for the people who can do something about it, it's good you hear this point of view. The Jitenge app was supposed to be for home isolation, if I'm not wrong, but it felt more like it was for quarantine than for isolation. The good parts about it is it kept giving me a reminder every morning to give in my vitals and my symptoms. The numbers were there. I'm not very sure if the numbers were working. I didn't try them in case of any emergencies. On a personal follow-up, I think for me, I'm not going to complain. I had a lot of follow-up from a lot of people, but I'm not sure if it's a structured follow-up or if it's if it's an actual follow-up. So they're colleagues of mine who've called me every single day until even until now. So yes, home-based care is very tricky, and for me it's easy because I'm a healthcare worker. I know what to check, and then the biggest question that I always have is for people who desaturate, what happens? Because I've also heard of people who are going back with SATs of 70s after being discharged with a positive test for home-based isolation. The happy hypoxia that I've seen in COVID patients is real. I've seen people who are working, like I said, I had family members who've been positive. So I've seen people working with saturations of 40. So how do we handle that? Yeah, basically, I think I have more questions than answers when it comes to home-based care.
Thank you, Dr. Amina, for that. We'll have Dr. Amber Gorey also giving in her views. Thank you.
I think mine is very similar to Dr. Amina, in that because I'm a healthcare worker now, of course, at home, because we are too infected, we are monitoring a bit more closely, and I know what to look for. The saturations, I know at what point to panic and go to hospital, how to measure the temperature properly, even listen to the chest with a stethoscope, and look out for some of those symptoms. I don't know, that may not be possible for non-healthcare worker families. So that is something that, as Amina said, needs a little more, or rather much more follow-up. So what happened, and even in terms of the ministry, I think I've only got one phone call, and they were just looking for contact tracing, and that was it. No other calls have come through. So I also have the same thoughts. Maybe I have more questions than comments. And actually, one I'd like to ask the infectious disease specialist is, now that, okay, we had it, and we are glad and lucky that either symptomatic or recovering, how much immunity, I know it may not be known, but if we go back, when we do go back to work, how much at risk are we of getting infection, or do we have some immunity for some time? Not that that means we stop taking measures in place, just health-wise, how do you know, or what is the information out there? Thank you.
Thank you, Dr. Bogori. Thank you for that. We had Dr. Mary Beth, but she has stepped out. We would have loved to hear from her some of the protocols and things that are being put in place. We'll have Dr. Nyukuri give some views on some of the issues that have been raised concerning what you say. Thank you.
Thank you, Agnes. I don't know if I've captured all the question. I'll start with the last question. How much immunity do you have? I've actually been reading around this. And based on my experience and based on the experience that other people have had, I'd say there is some level of immunity that patients previously infected with COVID do have. How much, for how long, is unknown. So what I can say is probably you are much better off than somebody who has never been infected in terms of immunity. But again, yes, please take all precautions necessary. Number two, somebody mentioned about home-based care and what we, and in terms of follow-up of the patients and what to do if a patient desaturates. I'll say, depending on, like here in KNH, we do use our, let me say our staff in the ID. They do call the patients who have gone home, just check on them. There's the Jitenge app. I know much more can be done than what is currently being done. And I just say if there's any staff who is on home-based isolation, and feels and feels unwell, should just call or come to hospital as soon as possible. Yes, I've noted 1 or 2 cases of patients who were discharged, went home, and later desaturated and came back. And I think this has been noted all over. And I think one of the questions then you ask yourself is, should we retain patients for a longer time just because a few of them might desaturate and come back? Because we really don't know who, at the moment, who may desaturate after being discharged, or who will be okay. To me, based on on our experience, the vast majority of the patients who are discharged do well. But on discharge, we do advise our patients that even as you're going home, please note that if you feel unwell, if you desaturate, if you feel anything that is not okay, call or come back as soon as possible. There's a lot about COVID that is still, we still don't know. Happy hypoxia is one of them. It seems probably it has something to do with how the brain senses oxygen levels, and probably it's sensing in COVID patients, it might not recognize the hypoxia as much as in normal patients. But again, as I say, there's a lot that we don't know. And if we can afford a pulse oximeter, that's a very, I mean, that's something I'll say most healthcare workers should have at this moment for ourselves and our families, so that if there's one of us has COVID, either on home isolation or after discharge, then you can be able to check saturation levels, and it will help. Thank you, Agnes.
Indeed, Dr. Thank you. That is very true. Indeed, we are living in very precarious times, and it's a disease that is evolving day in, day out as we live it. So we still find new things as we go along the way, and we adjust to the same. As healthcare workers, we are at a very mid stage. We deal with the patients, and at the same time we have our family, we have the community, and as we know that there's already community spread. So we have what I can say a double risk of getting the infection. And so all the precautions that we have been saying, we need to still continue adhering to them as we go along and as we still discover this disease. We have a question for Dr. Bernard Minor. You said that there were a bit of symptoms when you got discharged. There was when you got ill, there was loss of smell. Is that back? How are you faring on? How are you ensuring that you keep tabs on your health, even as you do the post-COVID care? Thank you.
So the smell came back 2 days after I lost it. I never lost taste. The fevers reduced after 4 days of antibiotics in hospital. The cough has been persistent, on and off. Saturations have been okay. So yeah, generally symptoms are improving. I'm still checking my temperatures. I'm still checking my saturations. Yeah. Thank you.
Thank you. So it's really important here to do that follow-up as we hear from Dr. Ray. And right now we'll do a final round as we also just take a bit on the issue of stigma. As healthcare workers, have we faced stigma with being COVID positive, maybe in our family members, with the community? Is it still the same for us? Is there some psychological support that we get? And we'll maybe start with Dr. Gwantai Kome. Just tell us how has it been post and any issues to do with mental support. Thank you.
So as soon as I got my results, I think actually the same day, I shared, of course, with my department because I have to take time off work. Then I shared with my close friends and as well as my union. My group of union doctors from where I was posted? That is Meru. The support has been really good. I've been getting phone calls nearly on a daily basis. At one point, actually, when I stopped receiving them because everyone is calling, they're so worried. They think that COVID is so bad. But once you tell them that you are symptomatic, at least guys take a breath of fresh air and they're like, okay, fine. Keep doing what you are doing, isolation and whatnot. About the community where I live, primarily because I've been on home-based isolation, I haven't been moving out of the house much. Most of my stuff I can actually order from delivery apps. I don't actually literally ever walk out of my house unless I have to go pick something from the car or something like that. Other than that, I have not experienced much in terms of, is it called stigma or anything like that? Actually, no. The support that you give your colleague who's tested positive or who is maybe going through the isolation period alone at home is very important. I would urge you to keep doing it if you're doing it. If you have a friend of yours or a colleague of yours who is suffering, just call once in a while and check up on them. It doesn't hurt. At least good to know that someone is thinking about you. But for me, it has been more of smooth sailing than anything else. Over to you back, Dr. Rosa.
Thank you for that, Dr. We have a comment also from Dr. Amina Guled. Any parting shots in his mental support? What can you say? Thank you.
On the mental health, for me, I think I've experienced both. Okay. I've experienced another angle of the stigma that a lot of people don't talk about in these forums, of people not believing that COVID is there, because majority of the people in the house were asymptomatic, so all of them were like, "Niko na corona kweli?" So it was like you have to convince them that they have corona as opposed to the other way around. And, like trying to get people away from the house, like literally you have to lock the doors and everything because people want to come and visit as opposed to the other way around, like people running away from you. So my experience has been weird, but like I said, majority of Kenyans don't actually believe corona is real. And the stigma out there is from a different angle, maybe, I don't know. And the ones who are afraid are too afraid. If you do a social distancing with somebody who is positive, 2 meters apart, and you're both wearing a mask, honestly speaking, the risk of transmission is zero. So yeah, that is my take on the stigma of corona.
Thank you, Amina. Thank you for all your questions, but participants might not be able to answer your questions live or give you an opportunity to ask your questions live, but please put them on the question and post them to the panelists and you're able to see them. And some of the questions may be answered in a different forum in the oncoming webinars. Just that our focus for today was really hearing the experiences from the healthcare workers' perspective. And we might not go into the details of treatment and such. We'll have also our comment from Dr. Amber Gorey. What do you have to say?
Okay. So as my other colleagues have mentioned, it has actually been not too bad. Of course, number one, it's not really information that, well, for me, posted too widely, just a few people who are close to me, not because I have anything to hide, but just because You don't want to allay so much anxiety and make people worried. From the department, from my colleagues who are aware, because now of course they had to cover some of the shifts, there's been a lot of support, a lot of people calling to check up on you. Now fellow positives, as I don't know if there's another word to call it, but other colleagues who have tested positive, those ones now it's a different story, because you sort of have similar to today. How did you feel? How was the fatigue today? How was your chills today? What is your temperature today? So those ones have also been another support group. And I think personally, because of testing positive a couple of times, or rather the second time, there was that anxiety, or like hoping to go back to normal activity. And when that came out positive again, a bit sad, but look at the bigger picture, and that it once the bigger picture is that you're okay, you're healthy, you're still moving around and you're active, so it will end one day, it shall come to pass. So no much stigma. Mental health has been good. I have a good support system, and I thank God for that. And I really hope that a lot of people out there have the same, and that so that they're able to go through this well. So thank you so much again to the other panelists as well, and thank you for convening this webinar and inviting me to speak.
Thank you, Dr. Amber Gorey. Indeed, it's indeed very, very important to keep ourselves mentally up, as now we are healthcare workers. At the same time, we're finding ourselves in a position where now we are the patients. We have some information. At the same time, we need to take care of ourselves. We'll have a final also from Dr. Bernard Minor.
What I'd say is the experience has been rather pleasant. I didn't expect the kind of support I've received from colleagues, friends, and family. It's been amazing. I thank God for that. The care I got from the hospital was very nice. From the department, also was very instrumental in getting me admitted, getting me a specialist to come review and all that. So that was good. What I'd ask, especially as doctors, we need to speak up. There is an issue with insurance companies refusing to pay up for clients. So they will tell you that that pandemics are not covered and whatnot. And we have other pandemics in Kenya. HIV is a pandemic, cancer is a pandemic, and epidemics, but they cover them. But why would you then discriminate against COVID? I don't think it's right, and we need to speak about it. The other thing would be the rate of transmission of results. I think this is a major challenge, and we need to do better. We've had, like in my case, the results took 5 days to come out. Those 5 days, I think, were, if I had gotten the results earlier, maybe it would be the severity of the disease would be lesser. And we need to work on that. That would be my all. Thank you.
Thank you, Dr. Now, before I give Dr. Rosa, we'll have Dr. Nyukuri. Please give us a parting shot. What is the way forward as healthcare workers in these COVID-19 times, as we both treat, and also as we're seeing getting infected in the line of duty or in the community? Thank you.
Thank you so much, and thank you to all who have shared their experiences. What I'll say is COVID is here to stay until the day we get a vaccine or a treatment that will prevent others from getting. We are going to see more among patients, among staff, people we know, family and friends. And I'll say as healthcare workers, we are so used to treating other people, but when we are on the other end of the spectrum, it's quite challenging. I'll just say this is time to support each other. Those who have gone through this and they are cured, they are now much better. I think you can also be, should I say, goodwill ambassadors, or just encourage, if you hear a colleague, because I think this information, when somebody gets it the first time, it's really, really terrifying. I just encourage you also to reach out to other colleagues who may be at the beginning of the same. Encourage them. Just let them know that the majority of the patients will be okay. And just in case anyone has severe disease, again, there are avenues to assist and to help, because this is like a war, and we should not leave anybody behind. Thank you.
Thank you, Dr. Dr. Gwantai, comment. You can also give us your views just before we wrap up. And also you could answer, would you, if you continued persistently testing positive, would you go back to work if you're stable? Is it something you would consider? Thank you.
First of all, there's something I'd spoken to you about yesterday when us guys had a conversation before you invited me for this, and you had told me to bring it up during this panel. I believe part of the participants here are the people who are in charge of the laboratory department or Clinic 66. Now, the challenge I've noticed when I've gone there, which I'm very sure most of my colleagues who are not here but have also had the same challenge, is the extensive delay that people actually have to wait as they get their results. Not even get their results, even get the sample taken. The challenge we have here is that they are using the same testing area for members of the public and hospital staff. Now, the challenge here comes in that most of the time, you will not get a sick off until you have a positive result. Now, you may be symptomatic and you are still at your workstation. Now, you come there and you wait for like between 2 and 3 hours. At times, you come there at 8, you have to wait until 11:30 before your sample is taken. Now, imagine if you do that for 10 staff across the hospital. And the challenge of being told, just go back the ward and come back to collect the sample, that one, you end up messing yourself up, Kabisa, because when you come back, you find that the kits they've run out. So if the people who are in charge of the lab or Clinic 66 can hear this, and please try and see if there's any way they can go around working about this, to have a specific dedicated collection area for staff members so that you can easily relieve them so that they can go back to their workstations. We've had situations whereby nurses are going for the tests and, we don't have a lot of staff in the hospital to start with. Someone is supposed to be in theater, they are waiting for a test for like 3 hours, while at the theater, work is still holding on and waiting for them. So if they can look into that, that would be a very good bonus. On the other question you asked, it was about, could you please repeat the question for me, Dr. Rosa?
That is well noted, Dr. Gwantai, and I believe we have part of the participants from the lab. It is indeed been a bit hectic getting the samples, and it's a whole network issue. And that one has been noted, and we follow up with the correct people. And even national-wide, as we try to get results, even for our patients, and not only for us, that's something that is indeed a continuous is posing a continuous challenge. For the other question was if we would persistently test positive. Let's say for Dr. Amina, although Dr. Amina is in a special situation. If you persistently test positive, there's a question: would you consider going back to work if you're asymptomatic?
For us now, you have to remember, over and above being doctors, you're also students. We are registrars who have to have a certain number of weeks of which you have to work before we proceed to the next year or the next semester. So at the moment, we don't have guidelines per se regarding going back to work if your results are positive. Generally, it's of the opinion that until your results turn negative, you hold on, because you do know that we have colleagues of varied ages. It'd be quite tricky if they're working next to a positive person who is positive and has turned negative as yet. So I would be willing to go back to work. Like for me, I've been largely asymptomatic for the past 2 weeks I've been in the house. But I'm also cognizant of the fact that Dr. Nyukuri said that there are no viral particles detected, I think, on 10 days after initial tests for people who are largely asymptomatic. But this thing needs to be worked out primarily with the heads of departments, especially of the students who are doing postgraduate studies, or even the heads of departments of various units in Kenyatta, to come up with a working formula. Because you can imagine if I keep turning, take an example for Dr. Amina, who's tested positive a couple of times, or Dr. Amber Gorey, who's tested positive a couple of times. You know, this is time that is coming off your academic calendar. I will shudder to believe if I'm left behind by 6 weeks. I would be willing to go back. I have no problem with working. The problem is the university and the hospital will not accept that until there's a protocol that is outlined to that specific effect. Thank you very much to everyone who is participating. Thank you for the panelists. Have a good day and have a blessed week.
Thank you very much. We do appreciate our panelists for the feedback they have given us. Indeed, some of these things is work in progress in terms of protocols, and as we have said and all that. I'll now give Dr. Rosa Chemui, who will now round it up for us. Thank you so much for being an active participant. We do appreciate your feedback.
Thank you very much, Dr. Agnes and Nancy and the panelists for taking your time to actually share this information with us. So the take-home message we are getting from, especially our panelists who are discussing what they have gone through, the 4 doctors. We will work on the results transmission. We discussed with the lab, they were not able to join us on the platform. There was a concurrent meeting running at the same time, but we conveyed your concerns, and moving forward, the turnaround time will actually reduce. Thank you very much, Amina. Like you had said, you isolate yourself immediately. As soon as you see symptoms, you isolate yourself. You don't waste a lot of time. McKenna, it was very, very encouraging to see how you remained positive throughout, even when the tests are becoming positive and you're hoping for them to turn negative, and you're still remaining level-headed. For us, that is very encouraging. And I know for the 1,000+ participants that we are having in this platform, it is actually very, very encouraging. Marina, we wish you a quick recovery. I know you just left the hospital the other day, and we'll work on the results. This feedback is quite important for us. Same to what Dr. Gontai has echoed. So we thank you very much, Dr. Nyukuri, for offering your expert advice on the same. I know we were not able to answer many of the questions that were put, but the pertinent ones we've already answered. So we would appreciate even our participants for staying through for 1.5 hours in a hot afternoon like this one. We look forward to another session tomorrow at 2 p.m. Otherwise, we'd call the session off. So do have an enjoyable afternoon, and thank you.